So good afternoon, good evening, or good morning, wherever you are. My name is Horst Neuhaus from Düsseldorf, and it's a great pleasure to moderate the next live session together with Jeanin van Hooft from Leiden in the Netherlands. And our main topic is pancreatic biliary novelties. And we immediately start with the first presentation from Jeanin on pancreatic necrosis management of walled-off necrosis.
Hello, my name is Aken Andersen, interventional endoscopist of the Leiden University Medical Center, and it's my honor to present this semi-live video case to you, which concerns a 72-year-old male who was admitted due to a necrotizing biliary pancreatitis. In his 5th week of admission now, with new problems like nausea, vomiting, and spiking fever under antibiotics. CT scan showed several abdominal collections. 2 of them were percutaneously drained, but also a large 9 cm peripancreatic necrotic collection. So learning objectives of this procedure are demonstration of transgastric drainage with a lens, retrieving some fluid for culturing, and discussion of ancillary techniques besides drainage. So let's go to the endoscopy suite.
Hello, good day. Today we are going to perform an EUS guided cyst drainage, and I'm not going to do that alone. I will do that with quite an extensive team. You cannot see them, but we have support from the anesthesiologist to help to get the patient asleep with the propofol. Then I have a team of nurses at my side. We have a specially trained nurse completely at the back. And then we have my colleague, Dr. Andersen. And for those who do not know me, I'm Jeanin van Hooft and I'm a gastroenterologist at the Leiden University Medical Center. I will work with a Fujinon scope. This is the linear EUS scope, and I think you're going to appreciate the EUS image. So we'll introduce my scope further to get to the stomach. Also of note, the patient is on his back. And that's for the easiness of the procedure. And as you can appreciate, here we have the aorta. And you can nicely see the vessels going off. Then I will introduce my scope a bit further, go into the stomach. And we more or less immediately jump onto the collection. Let me see how I can get that better into view. Okay, I think here you can appreciate the collection. This is if I torque. And in the meantime, we are checking for vessels that might be in between. If I look here to the right side of my screen where we have now the errors, I think there is still some tissue, either debris. To me, it looks mostly like debris that might be in, but any other suggestion is welcome. I will now see if I can get a stable position with my scope, so that more or less just with only having one-handed scope I can puncture. I think this might be quite a comfortable position, and my colleague is checking what the distance is. First of the cyst, as you can appreciate, nearly 6 centimeters. But I think it's also important to check what is the distance. Also for the needle, if you want to enter the cyst. So I think the distance from my needle to my cyst is about 1 centimeter. So we should also check for adjacent vessels. If there are vessels in the track, I'm going to go through.
One nice feature of this endoscope is that it can display the range within which you can maneuver the needle before puncturing. So it's basically a representation of the range of motion of your elevator.
So I think we have a nice position over here. I'm going to open up the hot Axios. We're going to use the hot Axios today. As there is some debris in, it might be convenient to use the larger size. We're going now for the 15 millimeters. So if eventually afterwards, if needed, you can do a cyst necrosectomy. And if not, it's maybe just sufficient to get enough liquid out. I think it's important before you use this device that you really make sure the nurse is making it wet at the outside. Just to get it smoother through your scope. So the working channel of this Jeanin is large enough. It's still more convenient if you have the device made really as lubricant as possible. Here we have the device. We can burn with the tip of the device. I will get it through my scope. And now you can see it really goes smoothly. I'm going to fix the device on my scope. I'm going to see if I can make a comfortable position for myself so I can nicely look at the device, how it's all working. You see that I lost my nice view on the cyst, so I will talk a bit to get again in the right position. Okay, so we have a nice position now of the scope. We have mounted the hot Axios on the scope, and now it comes to the settings of the Airbe device. What kind of cutting are you going to use? And maybe we could have a look, and my colleague will explain what our settings are.
We are using a Airbe Vio 3 generator, which is touchscreen operated. For the hot Axios we use pure cutting power on setting 5, which is comparable to about 150 watts of power.
Device really adjacent to the cyst. It is connected, and now I'm going to burn into the cyst. Okay, this is always what you get. You always get a bit of scattering. I fixed now my device again and going to deploy the first flange. I always find this a bit cumbersome to get this yellow stuff out, but I made it. And then I'm going to unlock the first part of the flange, which I have to do on this way. And now we're going to deploy the first flange. You can appreciate that under the EUS. There it is. And what I would do now is fixed again. I can of course get it either a bit deeper into my cyst, but we also always like to tent.
It's already tenting a little bit.
Yeah, it's already tenting. So I push it in a bit. This is how you often start. You unlock. You're going to try to make it really upwards. That's what we did by now. And now I would appreciate to see on the endoscopic image where I do have the device. So I try to torque away and see where I do have my device. And you can appreciate it really at the lower corner of my endoscopic image. I'm trying to optimize it. So now I'm going to deploy the other flange. The endoscopic image, I try to take some distance, and I think that's going smoothly. Looks even a bit like, okay. If you appreciate the endoscopic image now, you see the fluid coming out. And now it's a bit of debate. Do we think it's necessary to dilate this access to the cyst? And while you are debating, I'm going to demount the catheter, and you think for a moment.
Because the patient has a bacteremia, we're going to take a sample of the cyst fluid using a pulmonary ball fluid collection device. Hi, welcome back to the endoscopy suite. Jeanin and I switched positions, and I decided to dilate the Axios in order to facilitate placing 2 double pigtail plastic stents, and maybe perhaps have a little peek inside to discern whether it's solid debris or more soft debris. Now we are using an 8mm hurricane dilation balloon over the wire, which are already placed in the cyst. So now you have a much larger access to place your double pigtail plastic stents. I'm choosing 2 5cm 7" double pigtail plastic stents. And in my experience it helps preventing the necrotic tissue of early obstruction of the stent. Now here you see me introducing the double pigtail plastic stent, but a little bit too quickly. and I almost placed it inside the cyst, but I grabbed it with my elevator, and now I'm going to try and salvage my error by slowly pulling back upon the endoscope. I'm still grabbing the end of the plastic stent with my elevator, and I'm slowly retracting because this plastic stent is being placed long over the wire. There's no real opportunity for the nurse to retract the stent back into the stomach. So I'm still retracting the endoscope back into the esophagus, and I'm trying to get a little bit of a view now, and I ask the nurse to pull back the guide wire under fluoro, and there we see the distal flange of the plastic stent deploying, and I'm going back into the stomach, and there we see we salvaged the double pigtail plastic stent. So I quickly placed a second double pigtail plastic stent in order to act like a spacer to prevent early blockage of the Axios. So with this, I think we're done for now.
And I was actually wondering, what would be the follow-up? When are you indicating to do a new endoscopy, or are you just going to follow him up with imaging modalities?
Well, I think for now we're going to give him 3 days to improve, and if he doesn't, we're going back in for a necrosectomy.
Excellent case. Thank you very much for this nice demonstration. It looked quite easy to perform. So is this the standard of care that you place plastic stents after the successful insertion of the lamps?
Yeah, I think it's an interesting question, and that's actually also the purpose why I changed with my colleague, because I normally would not tend to do so. I think there was a nice runoff of fluids from the cyst, so I would not directly go for it. In addition, the type of pigtails we are using at the Leiden University are pretty soft, so if you're going to use them, you have to really dilate upfront to get them in. Otherwise, they're kinking too early. So I do not always do it, depending on the debris that's in and on the area, the space that you have. I do not know what your standard approach is.
No, we don't place plastic stents, but otherwise we would do the same for the follow-up. If the patient improves, he won't proceed to necrosectomy, but just wait for the clinical course. And this, I think, has been also shown in your multi-center trial, that about 40–50% of the patients improve without necrosectomy. So thank you very much.